All right. Good morning or good afternoon, everyone, depending on where you're joining us from. Thank you all for being here today for our, our second of the AMS webinar series. Today's topic is building an antimicrobial stewardship committee in long-term care. My name is Jason Vanstone, and I will be the moderator for today's session. So we'll start with a land acknowledgement. So I'd like to acknowledge that the National Collaborating Center for Infectious Diseases, who's one of the hosts of this, the NCCID, is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabeg, the Anishinaabe, the Dakota, the Dene, the Nehitawak, and the Ininiwak nations. It is also in the heart of the Métis Nation. At the NCCID, they strive to honor the lands and their original caretakers in the work and are committed to working with their partners towards reconciliation. I'd also like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, we would like to take a moment to acknowledge the importance of the land which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. So just a couple housekeeping pieces before we get started. So everyone, all the attendees are on mute. The chat box is disabled. However, if you have questions, we would like you to please enter those into the Q&A box. And upvoting is active. So if someone's already asked a question and you really like it, you can give it a like and send it up the priority list. Recording of today's webinar will be posted on the antimicrobialawareness.ca website and on the YouTube channel that was started with the first presentation. And that antimicrobialawareness.ca is a collaborative website hosted by the NCCID. And then if you're having any technical difficulties, just email Crystal. Her email is right there, crystal@ami.ca. So just a quick piece about the CanAMS webinars. So this is our Canadian Antimicrobial Stewardship webinar series. The CAN sort of represents this positive learning community, highlighting the successes and opportunities that we can use to build evidence-based AMS interventions in a variety of settings. So as I mentioned, this is co-hosted both by the National Collaborating Center for Infectious Diseases, as well as the Association of Medical Microbiology and Infectious Diseases Canada, so NCCID and AMI Canada. It's a national collaboration that's developed with a network of stakeholders. And again, you can visit that antimicrobialawareness.ca website. Lots of great information for helping building AMR awareness and antimicrobial stewardship knowledge. And then there's going to be a webinars menu on there where you can also check out past event recordings and see registrations for upcoming events. So I believe we've got a quick poll here that should be active. You guys can go ahead and answer just a couple questions. One, which of these roles best describes you as an employee of long-term care facility, other health sector professional, patient or family member, or other studying and learning about AMS? And then the second one, if you work in long-term care, does your facility have an antimicrobial stewardship program? So just trying to get a bit of an idea about whom we are speaking to today. Give a couple seconds for everyone to get in their votes. All right, we've got our results. So there we go. Which of these best describes you? Looks like 45% of the folks here today are an employee of a long-term care facility, or another 45% the other health sector professional. And we've got some patient family, one patient or family member at least, and other people studying. And 23% their facility has an antimicrobial stewardship program. So hopefully for the 53% who do not, this will be a very useful presentation for you guys today. Okay, thank you all very much for that. So I'll just do a quick introduction here for our speakers, and we'll go through some learning objectives, and then we'll jump right into it. So I'm very pleased to introduce you all today to both Caitlin Sterner and Kim Dand. So we'll start with Caitlin. Caitlin is the Director of Continuing Care in the Saskatchewan Health, Director of Continuing Care in Saskatchewan Health Authority. Caitlin grew up in Prince Albert, Saskatchewan. She did her post-secondary education in Saskatoon, studying microbiology and nursing. In 2011, Caitlin began her career as a registered nurse in rural rural frontline nursing. She moved to Regina in 2016, where she has since pursued leadership positions in healthcare and obtained a graduate degree in health administration. Caitlin is a member in good standing with the Canadian College of Health Leaders and holds a certified health executive designation. Currently, she's the Director of Continuing Care, responsible for the complex long-term care homes in Regina, including the Wascana Rehabilitation Center and the Regina Pioneer Village. And Kim Dand is a clinical pharmacist with the SHA. Kim grew up in Saskatoon and completed her Bachelor of Degree in Pharmacy at the U of S in 2003. Shortly afterwards, she began her career in hospital pharmacy with the Winnipeg Regional Health Authority. She returned to Saskatoon in 2006 and continued her career in hospital pharmacy with the former Saskatoon Health Region, now part of the Saskatchewan Health Authority. She's worked at various practice sites, including the Inpatient Pharmacy Department, the TB Prevention and Control Saskatchewan, Special Access Pharmacy, the Positive Living Program for Hepatitis C and HIV care, and in-home care. And in 2019, she started her current role as a clinical pharmacist at the Parkridge Center in Saskatoon, specializing in complex continuing care and geriatric rehabilitation. So thank you both for joining us today. Very happy to have you here. For today's learning objectives, one, we're hoping everyone will be able to identify barriers and opportunities for building an AMS committee in their long-term care facility. Understand the importance of connecting with patient and family partners and identifying long-term goals for long-term care AMS committees. So with that, I will pass it off to, actually, I will share my screen, and Caitlin will be our first presenter. Just let me pull up your slides here. There you go. Take it away, Caitlin.
Thanks, Jason. Good morning, good afternoon to everybody. Thank you for joining our conversation today about antimicrobial stewardship in long-term care. Very grateful for this platform. Long-term care is rarely a headliner, so this is really exciting for me. Slide 2. So in the Saskatchewan Health Authority, our mission is working together to improve health and well-being every day for everyone. I am very grateful to contribute to our vision of healthy people, healthy Saskatchewan through our AMS efforts. Next slide. So today I present from Treaty 4 territory, the homeland of the Dakota, Lakota, and Métis. As a health system leader, I take responsibility and accountability to do my part in ensuring that the health-related TRC calls to actions 18 through 24 are acknowledged and prioritized in our daily work and effort to effect positive change in health outcomes, culturally competent care, human rights, and anti-racism. I am committed to being intentional and mindful in my role. I strive to live and work with purpose and integrity, recognizing that my path to reconciliation is evolving, and I appreciate opportunities to listen and learn and will continue to do so. Next slide. So Jason gave a nice intro, but again, my name is Caitlin Sternard, based out of beautiful Regina, Saskatchewan. I am lucky to share the same Wascana Park grounds as our beautiful Parliament building. My role, again, is the oversight and accountability of our specialized long-term care programs in Regina. So that's at Regina Pioneer Village and Wascana Rehab Center. That includes populations with advanced dementia, mental health diagnoses, hospice, palliative services, and complex behavior and medical care, such as our ventilator unit. Next slide. Thanks. So I'll take you back to the why of the creation of our local Antimicrobial Stewardship Committee. So in fall of 2022, Continuing Care Regina participated in Accreditation Canada's survey in our service areas and homes. Wascana Rehab Center did really well overall. However, we did receive follow-up evidence submission as a result of an unmet required organizational practice, or an ROP. So the terms of the ROP read that WRC provides care to ventilated patients which are considered complex. There's no AMS committee in place. The committee is required to be interdisciplinary, involving pharmacists, infectious disease physicians, infection control specialists, physicians, microbiology staff, nursing staff, hospital administrators, and information specialists. The program is to include interventions to optimize antimicrobial use, including audits and feedback tools, formulary of targeted antimicrobial utilization, strategies for streamlining or de-escalation therapy, dose optimization, and parental or oral conversions. The program is to be evaluated, ongoing, and results shared to the stakeholders within the organization. So in addition to this must-do reason for developing the work, the researchers found that AMS efforts reduce misuse and overuse of antimicrobials, improve patient outcomes through de-escalation therapy, duration of therapy, and allergy delabeling, maintain susceptibility, and a clear economic benefit related to fewer infection-related deaths, fewer infections from drug-resistant organizations, and just medication costs overall. Next slide. So as you may understand, this is a very detailed and complex task, and I quickly started down the rabbit hole, which seemed to lead me to a black hole. When I started delving into the fine details of AMS work, I went way back to my roots in second year nursing pharmacology and microbiology. And even then, the literature about antibiograms, dosing policies, restricted medications just became overwhelming. My next step was just to continue down that rabbit hole, immersing myself in all things AMS and to start asking for help. So I was reading former policies about antimicrobials and clinical standards. I discovered that choosing wisely document in long-term care with associated toolkits. I was reaching out to anyone I could think of within the SHA. Pharmacists, physicians, other long-term care homes, like Kim, my colleague in Saskatchewan, acute care partners, clinical integration, and accreditation supports. After many, many emails and roadblocks, it was the clinical appropriateness team, so Jason and antimicrobial stewardship pharmacist Kristen and Mel, who threw me a life vest and helped me wrap my head around next steps. Kristen sent me literature, including the CDC's core elements of an antibiotic stewardship home for a nursing home, and the AMMI document supporting a business case proposal for an antimicrobial stewardship program. Kristen knew that this wasn't a small or easy feat, and I would require resources, which I didn't have at my disposal. Considering the competing priorities in healthcare and the limited resource, I wondered how I'd make this work. Doing AMS work off the side of your desk and not in a dedicated department or portfolio would present challenges in engagement, sustainment, and collaboration. It seemed that every time I reached out to somebody, they'd lead me back to the same point: Jason, Kristen, Mel, and their team. So I'm incredibly grateful for their direction, support, expertise, and passion for this subject matter. Next slide. So after pulling myself out of the rabbit hole, I just broke it down step by step. So I started by developing a terms of reference for the committee, recruited and engaged stakeholders, analyzed what we already did and what we already knew, and just started doing the work. So don't recreate the wheel here. Next slide. So within our terms of reference, we identified a purpose, the responsibilities and accountabilities, the members, and the commitments. Each requirement here would satisfy Accreditation Canada's requirements. So our purpose in this committee was to advise, to recommend policies and procedures in relation to antimicrobial therapy at Wascana Rehab Center long-term care, to promote the appropriate use of antimicrobials in order to prevent and reduce the emergence and spread of antimicrobial resistance, to educate, to provide information and educational resources for healthcare professionals at WRC long-term care on antimicrobial stewardship-related topics in order to optimize patient outcomes, limit resistance, and control antimicrobial costs, and to implement, to drive the implementation of quality improvement projects related to increasing appropriate antimicrobial use at WRC long-term care. Slide. So once I identified who should be part of the committee, I actually had to recruit those people to participate. Again, this took a bit of persuasion. Sometimes it took direction because this was additional workload on top of an already hectic schedule. But it was required work. And no, we do not have an infectious disease physician or microbiology staff on this committee. In long-term care, you do have to be creative and work within the limited resources you often have. Next, I submitted a proposal for a patient family partner, or PFP, As part of the philosophy of care in SHA, patient and family-centered care is at the heart of everything we do. My hope here was to have somebody be involved and be an ongoing committee member to help me translate the committee work into quality improvement and education opportunities for residents and families. The PFP who I paired with did much more than this. Colleen was part of the Regina Antimicrobial Stewardship Committee for many years when it was operational and had already connected in with Jason and team. The stars finally aligned. Colleen brought a passion and very strong understanding of this subject. She sent me links and literature. She attended quarterly meetings, and she pulls me out of the weeds when I frequently get lost in the comfort of journal articles. We piggybacked onto some work that our local IPAC team was already completing, UTI surveillance in long-term care homes, assessing hospital-acquired rates, indicating clinical signs and symptoms for appropriateness of collection, and susceptibility results. We submit these reports and audits to accreditation as part of our evidence submission for compliance. Once we became a bit more fluid and comfortable in our AMS efforts, I asked Colleen and the rest of the committee for additional quality improvement opportunities or areas we could audit. Without skipping a beat, Colleen said, "Have you thought of hospital-acquired respiratory rates on the vent unit?" It was such an obvious place to focus on. This was the population we served that required us to start the committee. Colleen keeps me grounded by reminding me what we are trying to accomplish, for whose benefit, and why we do the work, and how we move it forward. She asks curious questions and challenges us to examine how we reach our frontline, our residents, and our families. Because, let's be honest, when we have our resident family council meetings, AMS isn't a hot topic. It's usually menu items. What are we going to do for fun and recreation? Lastly, we just did the work. It didn't come on a silver platter, and there were no additional time or resources allocated, but it was a must-do, can't fail. So we built it from scratch, and while it's still in early stages and consistently transforming, it's worth the effort. I am by no means an expert in the field, but this was an incredible opportunity to build relationships within the organization, to improve the care we provide, to educate our staff, and to draw awareness on the topic. Okay, so bringing us to present day. I'll say amongst the current state and pressure in our healthcare system, finding time to continually grow and support this work is challenging. But opportunities and accomplishments we had to date include guest speakers and presentations on penicillin allergy and delabeling. The First Line app was shared with our physician practice group with really positive feedback. And the viral prescription information was shared with frontline nurses and families with really good uptake, especially in the cold and flu season. Participation in a study with the Public Health Agency of Canada is ongoing right now, and that's focused work on the incidence rates of UTI and ASVs with targeted interventions and education. And then along with our quarterly AMS committee meetings, we do the monthly UTI surveillance audits. If I were to offer advice or supports to others starting out, I would say start small and focus. It'll seem overwhelming and broad, and you can't fix it all at once. So choose one initiative to focus and improve upon. Remember why you're doing this, your target audience for education, and the clients this will benefit, and try to get at their level. Get buy-in right away. Be clear that this is priority work and you have responsibilities and accountabilities assigned. Don't try to do it all yourself. And this won't be meaningful work unless it's given the time and dedication it deserves. So reach out to experts in this field. It's very clear that those who chose this line of work recognize and are passionate about the positive impact on our healthcare system this initiative will make. They'll be willing to share their knowledge, guide your work, and cheer you on. Great. So what is our future vision for this committee and building AMS work into our quality improvement initiatives? At a local level, I hope to be a lead and a resource for other long-term care programs to adopt and adapt our work into their home. The value of this work in long-term care is significant. So citing bias, it's highlighted that there is a need for well-designed studies exploring innovative and multifaceted solutions to AMS in long-term care homes. Considering that approximately 71% of antibiotic prescriptions for suspected UTIs were clinically unnecessary. Long-term care also has unique factors and often barriers, intrinsic and extrinsic to the prescriber, such as knowledge, resident population, including age and cognitive impairments, environmental factors, including in-person assessments and visit practices, and high staff turnover rates. Next, I hope we grow. I hope we broaden our impact and scope, looking at other targets and audits, growing the committee, increasing local interest to buy in and be engaged, and then reaching the residents and caregivers. Education. AMS work is often assumed to be driven by a physician or pharmacist, and while their impact is vital, we need to explore how other disciplines can be involved and make positive change. So just looking at it from a bit of a different lens, asking yourself, where is my opportunity to be impactful? For example, nurses have a huge role in educating their patients. So again, we use the viral prescription pad during cold and flu season, in early interventions and symptom management, in identifying appropriate clinical indications. Outlined in Piggott et al., nurses need to be responsible to prevent harm in treating asymptomatic bacteriuria due to the premature closure bias, concluding the presence of a UTI without searching for the true cause of clinical change in resident status. Our IPAC and public health partners, they guide our work, they provide audits and feedback, and support, educate, and provide direction during outbreaks. Our allied health professionals, such as physiotherapy and respiratory therapy, which at WRC we rely heavily on. They support our work with our complex respiratory clients with procedures like cough assist or chest physio, and they have an expert lens on assessment of respiratory related infections. And then our unregulated caregivers and our caregivers, including families. So considering some long-term care homes have a nurse to resident ratio of 1:80, maybe more, continuing care aides or nursing assistants play a significant role in client care. From washing to feeding to bathing to seeing skin condition to toileting and socializing with our clients. These are our first line eyes and ears to detect acute changes so nurses and physicians can use targeted questions to assess early and treat appropriately. This too is the role of the family members. They might say, "Mom just seems off today," so we can assess accordingly. Where we can improve here is through education. Very common verbiage from unregulated caregivers or families include, "Mom's urine's cloudy or concentrated. Dad seems confused today. Bill's really tired," or "Helen isn't eating very well. Maybe they have a UTI." Amenta et al. Discusses the requests from family members were often a compelling reason to order lab testing, and concerns from family dissatisfaction is a tangible stress for staff. This is a perfect opportunity to spark conversation about clinical signs and symptoms of UTIs, non-pharmacological interventions, and disease pathology. So lastly, what's my kind of pie in the sky goal? A provincial approach to AMS. Knowing we have the experts in clinical appropriateness, they need the resources to translate this work across the province and support from local and senior leadership. There's a multitude of competing priorities, and we need to value this work. Knowing that patient safety and quality improvement are key targets for the SHA, and ultimately AMS work is fiscally responsible, this is an obvious and beneficial goal. So this is some references of some work that helped guide this presentation and the committee work ongoing. Just like to say a special thanks to Jason, Kristen, and Mel in the stewardship and clinical appropriateness team. They were really instrumental in the development of this work. And congratulations to all the other leaders and advocates for AMS work within long-term care. Just end with a quote from Martin Luther King Jr. "We can all get more together than we can apart." Thanks so much for your time today.
Thank you. Thanks so much, Caitlin. I really appreciate that. All right, feel free to throw questions in the chat. In the meantime, we will switch over and let Kim provide her experience from Parkridge Center, which is located in Saskatoon. Kim, go ahead.
Hey, good morning and good afternoon, everyone. Thank you so much for joining Caitlin and myself today to hear about our experiences with implementing antimicrobial stewardship in the long-term care environment. And next slide, please. Just wanted to say that I'm joining you from Saskatoon, and I'm a long-term resident of Saskatoon, and I'm delivering this presentation from Treaty 6 territory, which is the homeland of the Dakota, Lakota, and Métis. And recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples by knowing what the land and the traditional people of the land offer us. So here's just a picture of our beautiful city and the land that we live on. And if you've never been to Saskatoon, I know it's the Paris of the Prairies, so hopefully you'll be able to visit us one day. It's quite a beautiful place in the spring. Not so much in the winter, but in the spring and summer is good. So next slide. I just thought I'd give you an overall view of what long-term care looks like. It's a really obviously abbreviated view of how long-term care and continuing care looks like in Saskatchewan. So I know that our audience is from a wide range of different work environments, and I thought that just by telling you what our particular practice site, my practice site looks like, that would help to kind of put the talk today into perspective. So in Saskatchewan, of course, we have when you have to be moved from your home for whatever reasons, if you're no longer able to stay at home, there's different levels of assistance. So assisted living is like the first level that we start off with, and that just involves, and this is really abbreviated, there's much more to it than what I'm going to say, but just meals and light cleaning, that type of thing. Here in Saskatchewan, our personal care homes are a little bit more specialized. So we have more assistance with personal care and things of that nature, but they still, they are privately run and they do have a cost involved with them. So there is obviously some oversight from the government agencies and support and that type of thing, but it's not quite the same as long-term care, which has more oversight from the health authority. And so long-term care, we're helping people who are more reliant for personal care, lifts, transfers, that type of thing, but also at our particular, at Parkridge, which I'll get into a little bit here, we have more specialized dementia care programs that help, basically dementia assessment unit, which we have that helps people who are living with dementia but just need some special attention on a more one-to-one environment. And also we help people here who are rehabilitating from events that have happened that brought them to hospital. So our geriatric rehab or rehabilitation unit is another specialized area that we have here at Parkridge. And so in addition to those kind of specialized areas here at our facility, we also have people who require the use of automatic lifts and also ventilators and those types of things. So more specialized equipment that we have here at our facility. So we are considered complex continuing care, I believe, but it's still, we do have quite a few people who live here who are just in the long-term care setting, and then those other specialized areas that I mentioned. Sorry, I just have a message here about the sound. Are you folks able to hear? I do not have headphones, so maybe, oh, you know what? I bet you I'm blocking my speaker here on my computer. 1 second, I'll just move a few papers.
We can hear you. It's just popping a little bit. So maybe just try muting and unmuting again and see if that resets your mic a bit.
Okay. Hopefully that's a little bit better. I just moved a few things around, so hoping that improves it, but if not, please let me know. Okay, so that just kind of gives you a quick overview of what our site looks like. And then as far as next slide for my role at Parkridge as a clinical pharmacist, it's a little bit different compared to other long-term care facilities in the province, because not everybody has a clinical pharmacy support role. So luckily, I am able to be here for a part-time position, 24 hours a week. Oh, I think I may have frozen. I'm just going to try doing something here.
You're good.
Sorry.
We can see you and hear you.
Okay, I'm just going to unplug one thing here. Hopefully this doesn't make my computer completely shut down. There we go. I'm hoping this might fix the problem. Okay, fingers crossed. So my role here at Parkridge, basically I'm here to provide clinical support to all the different members of the care team. So I do provide medication reconciliation for people who are moving in or out of our facility. I do medication reviews on a regular basis, and also that medication review involves a lot of optimization and deprescribing, if possible, of medications. Just there's lots of opportunity to improve on a regular basis for how what our residents are receiving and trying to meet their needs with those different medications. I do attend rounds weekly, so we have geriatric rehab rounds, dementia assessment unit rounds, and palliative care rounds weekly. And in addition to that, we have yearly care conferences for all of our residents. So that ends up translating to 1 to 2 care conferences per day for all the people who live in our building here. And also I do sit on multiple local and provincial committees. I do try to answer medication related questions and concerns when I can for residents and staff. And I also collaborate with the community pharmacy that provides medications for our home. And we do try to work together to solve any issues that come up, like drug shortages, or if there's any sort of therapeutic monitoring that needs to be done, or follow-up type things. So hopefully now that I've disconnected that cord from my computer, I'm hoping things are better with the sound. But let me know if it's not. So our AMS team here at Parkridge consists of a nurse educator, a nurse clinician, direct nursing care representation, so people who are directly on we call them neighborhoods here, so people who are working directly on the unit with our residents who know exactly what's happening. The resident, when we do actually are lucky enough to have a resident representative. So here at Parkridge, we call, or we refer to the people who are living here as residents. And so we're very lucky to have one particular individual who's very motivated and interested in learning about these types of things. What else can I tell you here? So we also have an infection control practitioner, and that person does help guide us with giving us insight from some of the endeavors that they're trying to take on from the infection control perspective, and projects that they've been working on, which I'll get to a little bit later. And then of course myself, the clinical pharmacist, so trying to help in any way that I can with my knowledge of drugs. Next slide. So the reason for change, the impetus for change here was mainly due to Accreditation Canada. So I consider accreditation a really valuable experience, and it's really helpful to help identify things like that could be improved upon. So I know a lot of people are like, oh no, accreditation, this is a lot of work, but I actually am very happy that we were accredited and found to have things that we can improve upon, especially this particular opportunity to implement antimicrobial stewardship. So when we found that out, I was very happy that we could try to contribute in any way possible. And just going back to the accreditation goals, I think Caitlin touched on those earlier really well, but I'll just forward that to the next slide here. So the requirements or the goals that are listed by Accreditation Canada are all encompassed here. There's quite a few details there, so I'll just leave that for people to review later if they want to go into more detail. But basically, it looks like a lot of information when you first look at it, and you're like, okay, what exactly is it that they want us to build in terms of an antimicrobial stewardship program? So next slide. So basically, this kind of was in my mind how I viewed this talk today, was that Accreditation Canada had this structure that we're supposed to build, like our Antimicrobial Stewardship Committee is kind of like represented by this frame structure, basically. And they give us the ideas of what it should look like, and they give us the requirements. And so that's kind of where this idea for me of building this house kind of came up. And we know what the requirements are and what the final product needs to look like, but we're not really sure how do we get there. So that's kind of where we were once we found out we had this gap from Accreditation Canada. And the next slide shows kind of how we felt as a group. So we'll just over there to the next slide. So basically, oh, sorry, back to the IKEA one. So, IKEA, yeah. If you've ever had any furniture from IKEA, you know that the instruction manual can be a little bit confusing and not super helpful sometimes, especially since it doesn't have a lot of guidance there. So I thought this slide was perfect because when you look at it, it's a bit overwhelming. It's like, where do we start? How do we know what to go with first? And so looking for tools, like if you've ever tried to build furniture from IKEA, looking for things online, like a YouTube video, for example, can help give you a little bit of guidance and end up with a little bit less frustration at the end. So that's kind of what I'm going to compare these next few resources to once I get to some information that can give you folks to help guide with the process. So next slide. So how did we get started? So basically we connected and collaborated with the Antimicrobial Stewardship team in Regina, which includes Jason and Mel and Kristen, and we were very lucky to have them support us through this process. And I know Caitlin was singing their praises as well, and I can't say enough about how lucky we are to have this team in Regina that's willing to give us some insight and some guidance. So they were great. It's like in my analogy world, they would have been like IKEA super builders or something. They knew all about the furniture, they knew how to put it together. And so they helped guide us with the whole process, which was wonderful. We also had connected with the infection practitioners in IPAC, the nurse educators here, of course, the nurse clinician. And so basically those people I all mentioned there earlier were all part of our team, and they were all ready and willing to support our work here after we found out that there was that accreditation requirement. We have resident care coordinators here who are basically helping with the direct hands-on care on the neighborhoods, which I had mentioned earlier, but also have a clinical role as well. So they were more than happy to help support our work. We do have support from managers, physicians, colleagues in other facilities like Wascana, like Caitlin. And so we're just kind of basically trying to get connected to those people who are either like-minded or who have been through this before and can help support the work. So that was kind of like our first step. And then yeah, next slide. So the next thing after that, once we kind of figured out who we can get connected with and collaborate with, next thing to do was our homework. So what do we do? How do we research? Where do we look? So luckily there are some really amazing resources out there. And basically these resources are like the YouTube video I had mentioned earlier for trying to put your furniture together. So they're not YouTube videos per se, but they are very well documented, really well resourced guidelines from the CDC and also Ontario Public Health that I found were really great in getting us going and giving us some sort of structure. So I'll just go on to the next slide and discuss the CDC recommendations a little bit. So here is a listing of the different recommendations in the CDC document. So sorry, Center for Disease Control, of course, is what I'm referring to. And basically, they're looking for these elements that they're describing that will help to support a program. So that idea of having that commitment and support from leadership, to have a group of people who will be accountable and who will follow through with assisting in projects and activities that will help improve antibiotic use. Having that background knowledge of drug expertise is helpful to help basically guide the decisions and support the work that we're doing. Action, so at least pick one policy or practice to improve. So that's really important to just focus on one thing at a time, because it's definitely big work that has lots of different areas that can be addressed. It's just trying to focus on one thing and doing that really well is something I believe that Jason said quite a few times. And it's like, let's just pick that one thing to start off with, which is really helpful. Monitoring and tracking how that endeavor or how that project is going is also really important to see how you can improve on that, and reporting back to the staff and to clinicians, nurses, managers to see like this is what the outcomes are of the initiative that we're trying to do. But honestly, at the bottom here is education, and I kind of feel like that is actually one of the most important things, and that should be right at the top, because trying to do all this work and developing these committees is kind of difficult to do if you don't actually have the understanding, like the base understanding and knowledge of why are we trying to do this. Because in our world of long-term care, there's a lot of ideas that have been around for a long time about, and specifically with us, maybe I'll elaborate on this a little bit more on the next slide, but it's more about trying to address those ways of thinking and those older practices that can be improved upon, and education and things that have changed with those practices. So I'll move on to the next slide. So these are two different resources that I found on the CDC website that are actually really good for printing off and giving to people within the facility to help understand what it is exactly that people within the Antimicrobial Stewardship Committee would be doing, and then what people within the nursing home can do to support that work. So mostly from like a manager perspective, what can they do to help support it? And so I thought that this would be like a really good reference for people to take a look at, in addition to all the other documents that are on their website. But I just thought I'd point these ones out just because when you're getting started, there's lots of questions about why are we doing this work. And that was one of the challenges that we faced, was basically people thinking that this might just be a checkbox, like something that you need to get done for accreditation so that we can move on. And myself and the members of the team we're all really lucky because we definitely understand the value of this work and understand like the long-term goals of it. So it's basically, we know that it can have a huge impact, but it's not just something that's going to happen overnight, and it is something that is really valuable, and we can see the end result, the end project, the finished house or the finished piece of furniture. But we just we know that there's a lot of competing demands, like Caitlin was saying, in healthcare, for where do you put the resources, where do you put your attention. So trying to give that base knowledge to people about why antimicrobial stewardship is important and what the actual goals of delivering that type of resource or improvement, and also giving this to the leaders of the building would also be helpful, just to help so they have something to go off of when people say, how am I supposed to do this? What is this for? Why are we doing this? So next slide. So this is the Public Health Ontario Antimicrobial Stewardship Essentials tool that we used. And basically this tool and the website is, from what I can tell, really heavily based on the CDC recommendations. And the really nice thing about the Public Health Ontario recommendations is that it's, and this is like not the best word probably, but it's Canadianized. Like it's made for, it's described in a Canadian healthcare setting. So CDC, of course, is based out of US. So it's a little bit different when they're describing the roles and the healthcare system and how things work. So this one I found was really easy to use, and also really just focused on an environment similar to our own. And then I believe the next slide just describes that a little bit more detail. So like the similar list for essentials that were described in the CDC document, this one also has kind of like a stepwise approach that has the different elements that will help to build that AMS team and do that work. So the team, of course, we have to build that first, and then goal or aim to try and change the facility. So test it and sustain it so that we can improve upon what it is that we're trying to do. Just saying my internet is unstable. I'm hoping that people are able to hear this. Is it going through okay?
It's just lagging a little bit, but I think we're keeping up with you.
Oh, sorry about that. Okay, so I'll just move on to the next one. So those core elements that were described before actually correlate to these really great checklists they have on their website, where you can go through each different step and kind of break it down on what do you need to do in that step to get it established, basically. And so the nice thing about that was it gives you ideas on what you can do to change the far right-hand side here column. So there's pages of this checklist that you can download on the document from their website. And it's really great for just guiding the process and also providing references. We'll just move on to the next one. Okay, so that's enough about the Ontario program, the public health program. This is the HSO Antimicrobial Stewardship Program, which I'll just briefly discuss. I found this as well. We were looking through accreditation resources, and this particular document is more at the organizational level or policy development level. So it is helpful if it's somebody in a position that's trying to basically do policy development or things along those lines. It can be helpful, but it also has some other really good resources in it as well. It has basically one really interesting resource that I found was that it had client and family information to kind of help them to know what to expect from an antimicrobial stewardship program, which I'll discuss a little bit later when I discuss the role of having client and or resident and family involvement. But we'll just move on to the next slide, but I can also give you another reference that I found. So there's an agency based out of the US called the Agency for Health Research and Quality. And this particular website was great because it had some examples of what policies and procedures or how to gather a team, how to assess readiness for your site. So those kind of references I found were kind of unique to that website alone, and some of the other websites that I went to or references didn't have all that information. So it's great if you need like a template or a document, it might have some helpful information on that site. And just move on to the next one. Okay, so how did we get started? So after all that homework and research, which I have just gone into, I can tell you that we did have instruction to draft the terms of reference. So that was one of the things that accreditation wanted. So we were motivated to do that. And it's always nice to have that accreditation expectation to kind of guide you and say like, okay, this is the deadline, because otherwise things can lag on and take a while, kind of like my internet. So it's nice to have some deadlines and some goals to work towards and some guidance. So accreditation said that we needed to get this terms of reference put together. So we did some research on that, and we had some help from Wascana as well and from the team in Regina, the AMS team. And so we put together a terms of reference that kind of included these elements here that I listed in this slide. So I just gave a little bit of an example, and we used our organizational template, which was great. So we didn't have to try to reinvent the wheel there. Let's move on to the next one. Okay, so starting point. So we agreed upon an initial focus would be screening and data collection for ASB or asymptomatic bacteria and UTIs. So we worked with IPAC because they were our infection prevention and control committee to actually collect the data and try and implement a project basically that they had already started, but we had just tried to be supportive of that project, which we can describe a little bit more detail in the next slide, and that was something that we're still working on. Okay, so I guess, sorry, that one will be in a little bit later slide. So what have we accomplished so far? So we've made a commitment to meet every month, once a month, and we've actually been able to keep that up, which is great. We've raised awareness within our work facility and within the home here. And so we had an education day last November where we had the Regina team, the AMS team, including Jason and Kristen, were able to come visit us here in Saskatoon and provide focused and specialized presentations to nursing staff, to physicians, and to family members and residents. So it was really wonderful to have them come spend the day with us and to be so willing to offer that education in different formats. If you don't have a lovely AMS supportive team like we do here, there's always the option of just kind of creating those presentations on your own to help educate the staff and the residents at the facility. And if there's somebody who's willing to discuss maybe with the physician group as well, that just to kind of educate on some newer information that's come up with how ASB and UTIs are handled. So that's how we worked on that part of it. Next slide. So what are we working on now? So this kind of goes back to what I was mentioning before about the project that we're working with infection prevention and control. So we're still providing ongoing education to the staff about UTIs and the importance of completing the case for screening ASB versus UTI. So there's a form that's been developed that basically helps to navigate the clinical assessment of somebody who is presenting with symptoms that might be a UTI, but kind of guiding you through that process to see what are the chances and kind of to keep monitoring to see if things get worse or if things improve. So it's basically, there's like a nursing assessment form that's been developed, and also there's the suspect urinary tract infection case report form, which we basically collect data and submit that to a local IPAC person and also provincially to Jason with the AMS committee to try and help assess basically the rates of UTI treatment, whether they're if we're treating appropriately or if there's chances that maybe we're treating asymptomatic bacteria. So that's kind of like a really big overview of that. And if anybody has more questions, we can always ask Jason about that because he is definitely the expert in that area. We also do have a monthly review of antibiotic usage reports here that we have our local pharmacy print off, and we compare that to microbiology urine culture results to see if we're treating, if we're reviewing those results thoroughly, and if we're treating things that with the right drugs, basically. So just making sure there's that review. Okay, so next slide.
Might have lost Kim momentarily. Oh, there we go. I think you're back now.
Sorry, guys. My apologies. Okay, so barriers and challenges. So this is kind of where we can get into some of the things that you might expect along the way if you're trying to implement an AMS committee. So it's important to accept that it's a slow process, and it kind of needs to be something having to be maintained. And so trying to do this work is it's challenging because of the limited time that we all have in healthcare. So there's just never quite enough resources or time to get everything done that we want, but it's important to try and fit that in for sure. And so picking something small and working on that and then working on the next project afterwards, it's important to recognize it's going to be slow and it's going to take time, but that's okay. Working on long held beliefs is also really challenging because there are those perceptions out there that basically treating somebody who presents as having a UTI is a safer option than waiting it out and seeing what could possibly happen. Like, we don't want to ever take the risk of having sepsis, of course. So there's always that fear that if we hesitate to treat, that we might be deferring somebody for too long and that could end up in a worse situation. So knowing what things to monitor for and helping educate the staff so that they feel confident in making those assessments, so that really if it is something that needs to be treated urgently, that we can recognize those signs and symptoms right away and not have that fear of deferring something that could end up in a worse result. So that it's a little bit tricky to know that there is value in waiting and to try and instill that knowledge into the people that provide care. Also, there's that risk versus reward. So knowing that clearing up a UTI right away and clearing up someone's condition if they're having behavior changes seems like an immediate benefit as opposed to the long-term goals of preventing antimicrobial resistance. So you see the benefit right away, or you think you see the benefit right away if you treat someone's UTI, but you don't always see those long-term like goals of having reduced resistance rates and having more antibiotic options available. So I think those are some really important points. And since we're just running a little bit short on time, yeah, I think we've covered most of the other points here. Of course, asking people to do more with less resources is always tricky. And then, oh yeah, the other thing is maintaining that momentum or the drive or the energy that is gained from the initial excitement, I guess, if you want to put it that way, for trying to meet those accreditation demands once we, or requests or recommendations, once we meet those accreditation and get their approval, then how do we keep the momentum going? So that's the tricky thing, is not kind of getting complacent with things. Okay, so sometimes we feel like this. Sorry, the next slide we'll just go to here. So we feel like we're working without all the proper supports, and we're kind of doing the best we can without all the resources we can have. But that is the way it is in healthcare sometimes. And I'll just quickly breeze over the next slide here, because I know we're getting short on time. So resident family-centered care is a really important part of this whole process, and trying to find a resident or a family member, or both if you're lucky enough to help support this work, is really valuable. It really helps us when we have our monthly meetings to have a resident there to help keep us putting things in perspective and having that sense of humility and reminding us of who it is that we're actually working for. It really helps us to put ourselves in their shoes when we're discussing things that might seem like higher level, like policies and procedures, but actually know that when you're explaining it to the resident who's there at the meeting, that it actually helps make it understand what the purpose of this is. It's also helpful to help remind us that not everybody presents with the same symptoms for UTI, so that when we're discussing, and since we focused on UTIs right now, when we discuss that, it's good to have our resident's perspective on what he encounters when he has these issues, and how that we can put that knowledge into place as well. What else can I tell you here? I've just got a couple more slides. Yeah, there's just another one here about from the HSO document I mentioned earlier. That's just a reference on resident-centered care. So it's a really good, it's just a quick slide that you can review later if you like, and basically gives the resident and family expectations of what they can expect from the AMS program. And getting close to the end here. So what are our long-term goals? So we're hoping to use the data that was collected from the UTI surveillance forum and using that for quality improvement purposes to try and help streamline our prescribing patterns, and also maybe hoping to prevent some unnecessary prescribing. We're trying to, like in long-term, getting dedicated resources for quality improvement, including AMS, would be quite lovely to have that support, that extra resources, but we know that there's always competing needs within healthcare. So in the long term, hopefully we can find a way to get dedicated resources, ongoing support of further training for the members within our team so that we can help support education within our facility would be a long-term goal that we would really look forward to hopefully getting to as well. And then of course the overall goal of reducing inappropriate antibiotic use. So those are kind of the long-term perspectives. So like this building, which you will see scattered throughout the prairies, and I'm sure you might even have them all across the country, we're hoping to develop something that will stand the test of time. So even though it might not turn out exactly the way that we maybe initially pictured it to be, it's something that will stand and hopefully be a long-term way to improve the lives of the people who live within our care and within our facility. So that's it for me. Thanks so much. And I'll pass it back to Jason.
Thanks so much to both of you. Really appreciate it. I appreciate also anyone who's joined. We're at the end. We'll take maybe an extra 5 minutes just to answer some of the questions. If someone has to leave, please feel free. The recording will be available. And I see Karen's question there, and I do believe, correct me if I'm wrong, Crystal, but I believe that the recording will be sent out and it'll be attached. You can find it on the Antimicrobial Awareness website with a link to that YouTube playlist as well. So thanks so much, both of you. I feel like I do have to say too that there was no money exchanged for all the kind words that they have given to our Regina team here, but it's been a great opportunity to work with you guys and just see this flourish in your facilities and see what you guys have already been able to set up. So, but thank you for all the kind words. So we'll just look into the questions here quickly. So there's a question about having a copy of the slides. Are you guys okay with being able to share your slides out? Yes. All right. We'll go to Kristen's question there. So again, a thank you. As you acknowledged, even though you might not be an expert in AMS yet, there will be many people on this who are starting antimicrobial committees on this who won't be either. So I know you guys have provided a lot of insights. Is there any other suggestions that you have for resources where people can build their knowledge or competence in both stewardship and infectious diseases? Anything that you guys made use of? I'll start with you, Caitlin, there. Go ahead.
Sure. I would say, the Choosing Wisely document was probably one of my best resources, and it's consistently used in our practice now here at Wascana. The AMMI business case proposal was really great because, like Kim and I discussed, this work is really off the side of our desks. So putting forward a case to those senior leaders to say, hey, we need additional support, and what does that look like? Even if you don't get it, just to put it out there to say, this work is being done and it should be recognized. I know Kim shared the Canadian tool with public health, which kind of mirrors the CDC document, but I like how it is designed for Canadian healthcare systems. And then the First Line app, I think, a lot of younger practitioners and that, in the way of technology, I think people like to have an app and have the information at their fingertips. So that's been really well received in our physician group, and they're not a young physician group. They all have 50 plus years of experience. So even they're really loving that. So those are kind of our go-tos for resources.
Thanks, Caitlin. Anything you want to add there?
No, I'm actually right in agreement with Caitlin. All those references that she mentioned were really great resources, and I often will use the First Line app as well, but I feel like that may be specific to Saskatchewan. Well, I'm not sure if that's something that other provinces can access.
They can, yes. It's your health would have to buy into it. So Saskatchewan has purchased and been able to use that. We've got our own stuff set up. There are places across the country that use it, but not everywhere. So
yeah, I find First Line is really helpful here. It's kind of taking the place of me using, I don't know if anyone else on the call here has used Sanford's in the past. It's a great reference too, but First Line helps to basically give me also some site-specific information on LTC urine information for cultures and to see what's actually sensitive within LTC specific to Saskatoon, which is really great. So yeah, those active base well. If there's anything else that I can think of, oh, here we go again.
spotty Wi-Fi today.
There we go. Nice. Sorry, I'm back again. Both this internet. If there's anything else I can think of, I will send. Oh, I know. I'll send my information to Jason or Crystal to add to the meeting information.
Sounds good. Thank you so much. Thanks, both of you. So yeah, we'll put it to a close there. I know there's a couple questions we didn't get to. You guys can feel free to reach out to myself or Kim or Caitlin directly. I can always direct you to them too if you have more questions. So just a thanks for attending. A recording of this, as we said, will be available on the antimicrobialawareness.ca website and that YouTube playlist. There is an evaluation, so you can scan the QR code there, take a couple moments to fill that out, please. Make sure that we're creating the best content for you guys for this webinar series. And then, yeah, check out that antimicrobialawareness.ca website for new events. The next one will be in October of 2020. before, and it'll be around acute care AMS and what can be done with few resources. So thank you again, Caitlin, Kim, very much. Thank you to the organizers for bringing this on, and thank you to everyone for joining today.